Ansara Piebenga, and my daughter had a combined kidney and liver transplant. And I volunteer for transplant families. And I'm delighted today to introduce to you a true expert in his field who's done so much good for the pediatric kidney transplant community. His name is Dr. David Hooper. He earned his medical degree from the University of Utah Medical School in 2003, and then he pursued his residency in pediatrics and his fellowship in pediatric nephrology at Cincinnati Children's Hospital Medical Center. He's been on the faculty at Cincinnati Children's for 14 years, and he's now the director of the Anderson Center Learning Health Networks. In 2016, he launched the Improving Renal Outcomes Collaborative, IROC. It's a network-based learning healthcare system focused on improving health, longevity, and the quality of life of children with a kidney transplant. IROC now works with over half of all pediatric kidney transplant recipients in the US, and has standardized blood pressure management and treatment, has started to improve rejection rates, and houses the world's largest registry of COVID-tested pediatric kidney transplant recipients. We are so honored to have Dr. David Hooper with us today to speak to us about kidney transplant labs. Thanks so much, Dr. Hooper, for presenting to us, and now I'll pass it to you.
Thank you, Ansara. What a wonderful introduction, and it's always a pleasure to be with you and to hear how your family's doing. And thank you for everything that you've done to partner with us in our work. So I'm going to share my screen here, and hopefully this works. I presume you can see that okay, Ansara?
Yes,
okay.
We're good. Yep.
Great. So I was asked to give a Understanding Transplant Labs 2.0 lecture focused on monitoring kidney health. And so I'm going to share some things that I thought you might most be interested in. This is designed to be a supplemental presentation to a presentation given at the Pediatric Transplant Conference a couple months ago called Understanding Basic Transplant Lab Values. So I'm going to add to what was presented there by focusing specifically on kidney health and kidney transplant. So I'm going to show you and help with some understanding about the stages of chronic kidney disease in patients with a solid organ transplant. I think this applies not only to children with a kidney transplant, but also with a heart transplant, a lung transplant, small bowel, even bone marrow transplant, because a lot of those patients with time do develop some chronic kidney disease. I'm going to take a little bit of a deeper dive into how we understand the labs that we monitor to estimate kidney function so that you can understand what the physicians are thinking when they look at these labs. Then we're going to talk about other labs that are essential for monitoring chronic kidney disease. Finally, I'm going to spend a few minutes talking about the 5 shuns or TIONs of an elevated creatinine in a kidney transplant patient. So you can understand a little bit what your physician's thinking about when the creatinine's up. And finally, what I won't cover today, I'm not going to get into the immunology labs, donor-specific antibodies, cell-free DNA. I'm also not going to talk about infection, BK virus, cytomegalovirus, Epstein-Barr virus, and a whole variety of other things. I'd be happy to come back in a different talk and talk in more detail about any of these other immunology or infectious disease labs. But today I'm going to focus mostly on kidney health. So let's understand the stage of chronic kidney disease in patients with a solid organ transplant. And in order to do this, I want to tell you a story about a patient of mine. This slide demonstrates the progression of chronic kidney disease. We think of chronic kidney disease as having 5 different stages. Stage 1 chronic kidney disease means that you have normal kidney function, but your kidneys are not normal. And the patient I'm going to talk about was born with a condition called posterior urethral valves, which made it so that his kidneys did not develop normally in utero. But when he was born, his kidney function was normal, as estimated and measured by the different techniques I'll teach you about. But with time, as he got older, his kidney function did decline because the kidneys were not normal. First in just CKD stage 2, then CKD stage 3, then CKD stage 4, and finally end-stage kidney disease, which is also referred to as CKD stage 5. Unfortunately, if the kidneys fail and you progress to chronic kidney disease stage 5, that's not compatible with life. And so you need to have at least one of two different treatment modalities. There's dialysis on the one hand, and then there's kidney transplantation. This young man went directly to kidney transplant without needing dialysis. We call that a preemptive kidney transplant. And received that from his father. After that first kidney transplant, his kidney function from that transplant, he started that new transplant with chronic kidney disease stage 2, meaning in getting that kidney, the kidney sustained some injury through the transplant process. Of course, it's not normal for a kidney to be taken out of somebody and put into somebody else. So he started with CKD stage 2 after that transplant. And then with time, basically progressed through the other stages of chronic kidney disease. He graduated high school in chronic kidney disease stage 4. And then at age of 20, his first kidney transplant failed. And so he, this time, went on to dialysis for a period of time before he could receive his second kidney transplant. And after that kidney transplant, he actually ended up with CKD stage 3. So the kidney, through the kidney transplant process, was functioning only at a level of CKD stage 3. And then he graduated college, went on to finish grad school, and that second kidney failed. And he had to start dialysis a second time and finally received his third kidney transplant from his brother. And after that kidney transplant, he was at CKD stage 1 and has been on to doing some really amazing things with his life. So the thing I tried to illustrate with this is that the continuum over the course of a patient's life includes really moving through all the stages of chronic kidney disease. And even after a kidney transplant, every patient has chronic kidney disease. So let's talk a little bit about how we estimate the kidney function and are able to determine what level of chronic kidney disease a patient has. And to do that, I want to tell you a little bit about the kidney itself. This is a schematic of a kidney that's sort of sliced open. I like to think that the kidneys were named after kidney beans, but I think it might have been the other way around. Anyway, the unfiltered blood goes into the artery here. And that blood then goes out to the end of these medullary pyramids, and that's where it goes into these capillaries that filter the blood. And the clean blood then goes into the veins and returns into the circulation. And the urine is produced at the tops of these medullary pyramids and drips down into the collecting system and down the ureter. And it turns out that in the cortex, or the outer part of this kidney where all those capillary loops are, there are nephrons. And that's where I get my name as a nephrologist. I'm someone who studies nephrons. And the nephron is where is a wonderful glorified filter. It's the finest filtration known to humankind to date. No human creation is as sophisticated or as nuanced as this microscopic filter in your kidney. And what you see here is the ultrafiltrate, or the urine, goes into this space and through a bunch of tubules where all sorts of electrolytes and things are reabsorbed so that all the good stuff stays in your blood and all the bad stuff comes out in your urine. It turns out that a normal kidney has about 1 million nephrons. And the goal of those nephrons are a few things. Number one, they filter out toxins out of the blood and waste products. They also reclaim the electrolytes from the urine to maintain the pH of the body, maintain the acid-basis status, and to maintain good health. And the way we measure kidney function then is called glomerular filtration rate, or GFR. And that's specifically the amount of blood that can be filtered by all the glomeruli in all of your kidneys, whether you have 1, 2, 3, 4, in 1 minute, corrected for your body size. And the way that we display that is microliters or mLs per minute per 1.73 meters squared. And that's a correction factor for body surface area, realizing that, of course, a little person won't be filtering as much blood as a big person because their blood volume is so much smaller and their metabolic needs are so different. So that's the high level, specifically what the kidney is doing. Now, one thing to keep in mind is that when your nephrologist talks about kidney function, she or he are specifically referring to the glomerular filtration rate, okay? Sometimes the kidney isn't working well because it doesn't reabsorb fluid appropriately, or it's wasting electrolytes, or it's wasting protein. But if the glomerular filtration rate is normal, then your nephrologist will still say you have normal kidney function, even though there are some aspects of the way the kidney is supposed to work that aren't working. So just keep that in mind. It took me a little while to wrap my brain around that through my training. I kept saying, you keep saying this person has normal kidney function, but their kidneys aren't functioning normally. And what they're specifically referring to is how well are the kidneys clearing the waste out of the blood. Okay, so we assess kidney function in one of three ways. One, we can use biomarkers. These are blood tests or urinary tests to estimate the glomerular filtration rate, or GFR. We can also measure the clearance of substances in the urine. You might have heard somebody talk about creatinine clearance. Sometimes we'll do that. We'll do a 24-hour urine collection and see how much creatinine comes out in the urine. And then from that, you can calculate an estimated GFR. And then you can do direct measures of clearance of substances from the body by a nuclear medicine study or other things. This talk is focused on labs and biomarkers, so I'm going to focus on this first bullet point, but we'll touch on the third one briefly. So in the first lecture, you were taught about the basic metabolic panel. These are the tests of a basic metabolic panel, and this is actually how your nephrologist looks at them. It's a little bit like a matrix, and it's shorthand for how they organize this information to look at and process through. On the left-hand side of this matrix, you've got sodium, potassium, chloride, and bicarbonate. And these are basically the electrolytes, and the bicarbonate is telling you something about the acid-base status. All those things are regulated in the nephron. So we can see, is that nephron working well from those lab tests? And then the BUN, the creatinine, are what we often use to help us estimate the kidney function. So what are these things? So the BUN is short for blood urea nitrogen. And here's a little tip. So often we use acronyms and we just say them like BUN. People would normally say BUN. But in medicine, for whatever reason, nobody says BUN. Everyone always just says BUN. So if you want to look like a veteran at your trade, and you're talking to your nephrologist, call it a BUN, not a BUN. And that represents the nitrogenous waste from the protein metabolism in your body. It's also a marker of other uremic toxins that we don't really measure directly. One thing about BUN you need to know is it does increase with dehydration. It can also increase if there's absorption of blood or if there's an increase in protein nutrition specifically. And then it'll decrease with poor nutrition. So somebody that hasn't had good nutrition over time will have a lower than expected BUN. And that can be a problem if you're using it to estimate kidney function, because often in late stage chronic kidney disease, people don't eat as well or aren't as well nourished. And so the BUN can be deceivingly low. Creatinine is a protein that's produced by the muscle and filtered by the glomerulus in the kidney. So a higher value implies either increased muscle mass or decreased kidney filtration. And so, of course, this can be impacted by hydration, which decreases blood flow and therefore decreases filtration. It can also be decreased by malnutrition if you have low muscle mass or some muscle wasting because you've been chronically ill, or it can increase during periods of rapid growth. So a take-home point here is that BUN and creatinine must be interpreted in the context of growth, nutrition, hydration, and other factors. Normal values in the computer system can also be misleading, and so you really need to talk to your physician about what those values mean. So I want to teach you a little bit about the relationship between your serum creatinine and your glomerular filtration rate. Because you're measuring the buildup of a substance to determine how quickly it's being cleared from the blood, there's an exponential curve basically that demonstrates the relationship between serum creatinine and glomerular filtration rate. For a toddler, a normal creatinine might be maybe 0.3 milligrams per deciliter, and that might correspond to a glomerular filtration rate of 100%. If that creatinine doubles to 0.6, that would reflect a decrease of 50% or halving of the rate. So if you filter it half as fast, then the substance will build up and be double what it was. And so if you half that glomerular filtration rate again from 50 down to 25, the creatinine will double again from 0.6 up to 1.2. And then if you half that again from 25 to 12.5, it will double again up to 2.4. So one thing to keep in mind is that an increase in creatinine at the higher ranges reflects a relatively small decline in GFR, but an increase of creatinine in the lower ranges represents a relatively higher loss of GFR. And so it's just something to be aware of. And remember how I told you that creatinine is generated by muscle essentially. And so the more muscle you have in your body, the higher your creatinine will be. And so this is the curve for a toddler. For a child, a normal creatinine might be more like 0.5 or 0.6. And that would reflect normal kidney function. But, if that were to double up to 1, then their glomerular filtration rate might be cut in half. Whereas for an adult, a normal creatinine might be closer to 1. And so a creatinine of 1 in an adult is a normal thing, and a creatinine of 1 in a child is abnormal and reflects a significant loss of kidney function. And a creatinine of 1 in a toddler is suggesting that the kidney function is quite low. So a take-home point here is if your child is growing, their creatinine is going to increase, even if their kidney function is remaining the same. So it's really best to also use other biomarkers and estimating equations to understand kidney function over time. Enter cystatin C. So cystatin C is a protein produced by all cells with a nucleus in the body, and it's also filtered in the kidney by the glomerulus. So again, higher values generally reflect lower kidney function. And this is, I wouldn't say it's a better biomarker than creatinine, but it's a different biomarker than creatinine that is not impacted or influenced by muscle mass and growth like creatinine is. But it can be impacted by medications such as steroids or other metabolic conditions like thyroid disorders. So we like to use a combination of creatinine and cystatin C in our program to estimate kidney function. And we monitor cystatin C every 6 months. So to just illustrate the point, I think using creatinine or cystatin C to estimate kidney function is a little bit like counting cereal boxes and using that to estimate how often the garbage man comes. I suspect all of us, I know I do, I had some Quaker granola this morning for breakfast. And in order to live, that means if I eat Quaker granola, I'm going to generate some garbage, some cereal boxes. And I don't have very many cereal boxes laying around my house because every week the garbage man comes and takes them away. If the garbage man stopped coming every week and maybe came only every other week, then twice as many cereal boxes would build up than had previously been building up because now he's coming half as often. And if he came only once a month, now it'd be 4 times as many cereal boxes building up. And if he only came twice a year, then it would become very uncomfortable to live in my home because there would be so many cereal boxes piled everywhere. That's a little bit what's going on with chronic kidney disease. And so I think this is a good metaphor to help me understand the connection between creatinine or cereal boxes and kidney function, or how often the garbage man's coming. So how then do we actually estimate the glomerular filtration rate based on a creatinine? If you're a professional, you've been doing this for years, you can usually look at somebody, look at their creatinine and pick a number and be pretty close. But there are more formal ways to do that. And there have been many equations over the years to help us know how to estimate kidney function. And the most recent iteration, and one that is very effective, is generated by the CKID study that many of you may have heard about. It's the Chronic Kidney Disease in Children study. And they've developed the CKID under 25 or U25 GFR estimating equations. You can look this up. It's available for public use. There's an app you can actually use. And that will allow you to take the characteristics of yourself or your child, enter them in, and these equations that have been studied and validated over hundreds of children with various stages of chronic kidney disease. You can enter age, sex is assigned at birth, height, their serum creatinine, and their cystatin C. And what that'll generate is 3 values. The first is an estimated glomerular filtration rate based on the creatinine and the other values there. The second is an estimated kidney function from the cystatin C. And the third is then the average of the two, which tends to be the most accurate of all. So this young woman who's 17 years old and 157 centimeters with a creatinine of 1.33 and a cystatin C of 1.74 has an estimated GFR of 44 mLs per minute per 1.73 meters squared. And that puts her squarely in chronic kidney disease stage 3. Okay, so I'm going to talk briefly about, so that was the use of biomarkers, and hopefully that'll help you now, equip you to know how to estimate the kidney function of yourself or your child. Just a brief word about direct measures of GFR. There are ways to directly measure how quickly the kidneys are clearing the blood or how effectively. There's this chemical called inulin that's a gold standard. You've injected and it requires urine collection. There's iohexol, which is another thing that can be injected, and then with multiple blood sampling and some modeling, then you can estimate a GFR. And then more commonly, what some of you are familiar with because you've had this done, is the nuclear medicine GFR, where there's an infusion of a radiolabeled substance that is filtered at the glomerulus, and then they use radiation or a radiation measurement, basically, to understand how quickly that radio tracer is cleared from your blood. But the bottom line is that in almost all situations, eGFR, as estimated by cystatin C and creatinine, is sufficient. And most often nephrologists are not relying on nuclear GFRs because really the number is probably less important than the trajectory and how the patient is doing. And that's where we come to this figure here. So I talked to you early on about the different stages of chronic kidney disease, stage 1, 2, 3, 4, and 5, as depicted in this table here. And they are determined based on the GFR. So stage 1 chronic kidney disease is a kidney that's not normal, but has a normal glomerular filtration rate of greater than 90. Stage 2 chronic kidney disease is a GFR between 60 and 89. Stage 3 is between 30 and 59. Stage 4 is between 15 and 29. And then stage 5 or end-stage kidney disease is less than 15. And this is often when somebody will really need either dialysis or a kidney transplant. It turns out that the body is very resilient, and we are not capable as a medical field really of detecting stress in the body before chronic kidney disease stage 3. And it's actually not until maybe a GFR less than 50 where the body really starts manifesting symptoms related to chronic kidney disease. And those initial symptoms really are only laboratory tests. And so I'm going to talk to you a little bit about those laboratory tests. So what are the other labs essential for managing chronic kidney disease? And to do that, I just want to put the kidney at the center here. And this is a picture of another picture of one of those glomeruli with the arterial coming in and out, and the filtration of the blood and the creation of the urine. When this all works well, people thrive and do really well. And when this doesn't work as well, it can affect the neurocognitive development. It can affect electrolytes. It can affect the acid-base status of the body. It can impair bone growth and development and cause weaker bones. It can cause anemia. There's a hormone in the kidney responsible for prompting red blood cell development within the kidney. And so when there's poor kidney function, the red blood cells may not generate as well. The kidneys regulate blood pressure and a number of things that affect the heart. And finally, kidneys that aren't working well, patients can develop growth hormone insensitivity and therefore don't grow quite as well. And so these are all the things that can happen when the kidney's not working. And so when you've had a kidney transplant and you're at chronic kidney disease stage 2 after the kidney transplant, then paying attention to all these things is really important in order to optimize your health and make it so that you can have as healthy a life as possible. And so we will be monitoring these things on a regular basis. So starting up here with your electrolytes, I think as you heard in the first lecture, and as I mentioned earlier, these electrolytes really are checked on every blood draw with that basic metabolic panel or a comprehensive metabolic panel. The magnesium may not be checked every time, but these other electrolytes certainly are, and regulated in order to keep you healthy. We also, with every blood draw, take a measurement of the acid-base status in your body, and that's in the lab called bicarbonate, or abbreviated with the HCO3. In order to manage bone health, we're looking at calcium and phosphorus that comes with the comprehensive metabolic profile, and we often draw that with every lab draw to make sure that the bones are healthy. And then there are a couple of other, there's vitamin D and the parathyroid hormone that are important for bone health, and that can be in later stages of chronic kidney disease can cause problems for bone health. And so these levels should be monitored every 3 to 12 months or so, depending on the stage of chronic kidney disease. Those who are in early chronic kidney disease, maybe stage 1 or stage 2, may not require monitoring of the parathyroid hormone and vitamin D near as often, whereas patients in stage 4 chronic kidney disease probably should have them monitored every 3 months or so to make sure that the bone health is optimized. As far as tracking how well the kidney is helping to promote red blood cell development, we, with every blood draw, get a complete blood count. This was explained in the first lecture. And on that complete blood count, we're really looking at the hemoglobin, the white blood cells, and the platelets, the hemoglobin being what is driven often by how well your kidney is functioning. For your heart health, we like to check a blood pressure every clinic visit, and then every 1 to 3 years, we'd like to check a 24-hour ambulatory blood pressure monitor. It turns out that 24 hours of wearing a blood pressure cuff that measures your blood pressure every 20 to 30 minutes for 24 hours, we as a medical field can get more information in that 124-hour period than years of clinic visits. And it turns out it's the most reliable and best predictor of long-term heart health, especially the nighttime blood pressure. And so this is kind of an annoying thing that is inconvenient and a little difficult maybe to sleep with, but it gives a remarkable amount of data to your clinicians so that they can help you manage your blood pressure in a safe range. With every visit, we like to follow height and weight. And then with every visit, we like to see how you're doing with your quality of life and also whether you're meeting developmental milestones. So years ago, my colleague Donna Clays here at Cincinnati Children's Hospital, who thinks an awful lot about chronic kidney disease, with her team developed a helpful mnemonic to help keep all this chronic kidney disease stuff straight. And they called it Grab a Buck. And GR stands for growth rate, A for acidosis, B for bone and mineral disease management, and A for anemia, B for blood pressure and ambulatory blood pressure monitoring, U for urine protein, and C for cholesterol, weight, and cardiovascular health, and K for kidney, which is what we love in nephrology. And they created this thing to help us in our clinics to know whether patients were being monitored and treated for each one of those different labs. And you can see up here at the top, we've got the growth portion, linear growth. Albumin is another protein in your blood that can be measured to estimate your nutritional status. Here's your bicarbonate and potassium, both of which are related to whether there's acid building up in your blood because your kidney can't clear it well. Bone health, that's calcium, phosphorus, parathyroid hormone, and vitamin D. Anemia management, looking at the hemoglobin and iron stores. And these are two tests that I didn't mention. The transferrin saturation is a combination of the iron and a test called TIBC that will help determine whether your iron stores are full, which is necessary to help you build hemoglobin. B is for blood pressure, both in clinic and the 24-hour monitor. U is for urine protein to creatinine ratio, and are we treating any protein in the urine that we see? C is for cardiovascular health, including cholesterol, and checking for obesity. And if you wanted to read more, there's a new guideline, international guideline for the clinical practice of evaluation management of chronic kidney disease. It was published this year. It's 200 pages of pure reading enjoyment. It's available out there on the web for anybody to peruse. So as we look at all these things, there are treatments for each one of these areas of chronic disease management for chronic kidney disease. And these are the types of things that your clinicians will be thinking about as they follow your chronic kidney disease over the life of your kidney. Okay, finally, I want to just talk briefly about the 5 TONs of an elevated creatinine in a kidney transplant patient. What we have been talking about is chronic kidney disease, which is really the state of kidney function over time. And generally speaking, the kidney function will decline over time as a natural process of aging and injury to that kidney that it sustained in the transplant process or by other immunologic factors. There is a scenario where you can have acute kidney injury and where the kidney might be injured or not be filtering as well because of things that, if they can be treated or diagnosed, the kidney function will return back to its baseline. And these are the 5 TIONs of an acutely elevated creatinine. And some of you may have seen this before. I get this from my mentor, Jens Goebel, who taught me much of what I know about what I do. I'm forever grateful to him. The first TION is dehydration. So hydration status can definitely increase your creatinine. The kidneys that are transplanted don't come across with the nerves, which therefore are unable to help with autoregulation and reacting to lower states of hydration. So even mild dehydration can lead to an elevated creatinine in a patient with a kidney transplant. Of course, the immunosuppression we treat our patients with is essential to keep the kidney healthy, prevent the body from rejecting the kidney. And these medications are very good and very potent. But it turns out that if you get too much tacrolimus or too much cyclosporin, it can cause some injury to your kidney. There's a couple of other medicines like ACE inhibitors or Bactrim that don't really cause injury to the kidneys, but they can elevate the creatinine. And so if we see an elevation, we need to follow up drug levels and ask the question, have we recently started a medication that can cause an increase in creatinine? A third item we need to think about is infection. Really, any infection can increase the creatinine a little bit because it increases the metabolic demands of the patient and may lead to some mild dehydration. But this kidney-specific infections that we worry about also are urinary tract infections and an infection called BK virus. It's beyond the scope to go into great detail about BK virus, but it's something that's out there. The fourth item on the list is obstruction. Now, obstruction sounds kind of final, like there can't be any flow of urine. I think obstruction in our kidney transplant patients is often a partial obstruction or an intermittent obstruction or a functional obstruction. And what all those things mean is just some increase in resistance to the flow of the urine outside of the body. And if there is an increased resistance, that can cause back pressure on the kidney and can decrease the amount of filtration it does. And then finally is rejection. So there's your 5 TIONs of acutely elevated creatinine. And so if the creatinine's elevated, your physicians are going to start thinking through what could be causing this elevated creatinine. And the progression they go through is first, is this patient hydrated? And so those of you that live with kidney transplants probably get sick of your doctors asking you how well are you hydrating, but it's really to help them understand, wait, is this the problem or can I just check it off the list and move on to the other problems? And so often the physicians will ask you to hydrate aggressively and then recheck. Medication, of course, we're going to review the medications and evaluate the drug levels. For infection, we're going to do a urinalysis and a urine culture, and we'll check a plasma BK virus PCR. For obstruction, we'll do a renal ultrasound to look and see if there's any fluid on the kidney that represents urine that's not flowing. Incidentally, however, not all obstructions show fluid on the kidney, but certainly if the ultrasound shows one, then you can pick it up and treat it. And then finally is rejection, and that can only be diagnosed with a biopsy. But if you're considering rejection, checking for donor-specific antibodies or other types of biomarkers such as cell-free DNA might be something that your team will do. Okay, well, in summary, what we've gone through is patients with a solid organ transplant may progress through the stages of chronic kidney disease, including end-stage kidney disease. Every kidney transplant patient has chronic kidney disease. Estimating kidney function requires an understanding of multiple factors, including growth, muscle mass, nutrition, hydration status, and a variety of other things. And the best equation for estimating kidney function in children and young adults less than 25 years of age is the CKID U25 equation that uses creatinine and cystatin C. The body will start feeling the effects of chronic kidney disease about a GFR of maybe 40 to 50. And so that's really when the CKD management and monitoring needs to be stepped up. And you can remember grab a buck to help you remember all those things that need to be monitored. And then finally, there are 5 common causes of elevated creatinine in a kidney transplant patient, and they all end in TION. And that will do it. Thank you very much for having me come and talk to you all, and I hope to see you around at a future conference and would be happy to answer any questions.
Thank you so much, Dr. Hooper. That was really wonderful and tons of great information. We really appreciate that. And if you have watched this and you have questions, please send us an email to hello@transplantfamilies.org, and we'll get those questions off to David Hooper, Dr. David Hooper, and post those up on our website. So thank you so much. We really appreciate your time and sharing all this really important information.
Thank you.